And I think in 3 seconds we should be live. Yeah, we're live. Amazing. So good evening, everybody. Thank you very much for joining our talk today. We are the Aspiring Congenital Heart Surgeons Association. My name is Ayush, and we've got a lot of my brilliant colleagues here as well. And like we said over our last few talks, we want to provide a supportive and educational environment where aspiring congenital cardiac surgeons can thrive, learn, and connect with leaders in the field. This is all of our team at the moment. And like I mentioned earlier as well, we're looking for representatives from different parts of the world to engage with the society and also improve our outreach. So today's talk is by Mr. Nicola Viola, who is based in Southampton. He's a congenital cardiac surgeon. He's going to be discussing atrioventricular septal defects and repair techniques. I've seen a version of this talk before from Mr. Viola. He's an excellent speaker and an even better teacher. So it's something definitely we're looking forward to today. Keep an eye out for some of the upcoming webinars. We'll be having sessions on tetralogy of Fallot, congenital aortic stenosis, as well as global cardiac surgery. And in-person events will be coming soon. So make sure to stay tuned to our website, social media, and become a member. So without further ado, I'd like to introduce Mr. Nicola Viola.
Thank you very much. The board of this amazing association, which I come to learn about in June in a conference in Bologna, and it was an impressive presentation from the outset. And from what I see of your website today, that impressive output is confirmed also by your ability to use modern language, including social media and modern technology. So I guess a window in what the future holds for you mainly, but also for those of me who are fortunate enough to see a glimpse of it towards the later phase of my career. So I'll try to do you justice to both your, I would say, a thirst for knowledge and your organizational and managerial skills with a talk that will bring you some meaningful information and a little bit of insight in perhaps what is, I believe, one of the most complex surgeries to undertake in congenital cardiac surgery. I will share my screen now, and I hope that we can see some slides.
Amazing.
Can you see the presentation?
Yes.
Yes, we can.
Very good. So, as I was saying, before we carry on, I guess fair enough, in keeping with what modern standards are, I consult and I speak for Axial 3D, which is a company based in Belfast, which produces 3D print and also image segmentation for complex organs, but also for other non-cardiac professions. And some of the slides that you will see in this presentation are being borrowed by the presentation of Professor Anderson, and those who were at the ECHO congenital course would have seen this. And I do believe there are still the unmatched gold standard when it comes to the anatomical and the morphological treatment of any congenital lesion. So to go straight into the matter of the fact, I'm not sure, and I would assume that we have a relatively common ground when it comes to basic informations about anatomy and physiology. Not least because if I were to go into the detail of all the aspects of this lesion, probably an hour and a half wouldn't be enough. But I will say that the most important element to remember about atrioventricular septal defect, and regardless of how we get there from an embryological point of view, which again is a talk in its own merit, there is one phenotypic feature, one anatomical characteristic of the atrioventricular septal defect, which is the non-variable of this lesion. In other words, is the constant that brings all the different manifestation of AVSD together, which is the presence of a common atrioventricular junction. This is different from a normally developed heart where you would have two separate atrioventricular junctions, one between the atrium and the left ventricle with the mitral valve in between, and one between the atrium and the right ventricle with the tricuspid valve in between. So the only element that really defines atrioventricular septal defect is that instead of having two atrioventricular junction or two annuli with the relative leaflets and subvalvular apparatus, we got only one. And this one is serving both ventricles. Once you keep this in mind, all the subtext, all the different classification, partial, complete, intermediate, are effectively a misnomer in as much they don't represent a different type of AVSD, they represent a different manifestation of the same lesion. And the difference between those two has got more to do with the presence of interatrial or interventricular communication and the amount of shunting between them. But none of those changes the fundamental element, which is the fact that the valve is one and the atrioventricular junction is common. You can see in this image, which is that of a heart, which is looked at by the base looking towards the apex. The atrial mass has been resected. So what you see here is the raw surface of the muscle where the atrium has been resected. You see on the top, the root of the aorta, and on the bottom, a large single hole with leaflet tissue in the midst of it. These are the leaflet components of the common atrioventricular valve. But as you can see, there's only one circle. There are no two circles like in a mitral and tricuspid valve system arrangement. The second thing that you notice is that the aortic valve and the aortic valve root, the aortic root as it were, is so-called unwedged. In other words, because of the lack of separation of the two annuli of the tricuspid and the mitral valve during gestational age, the aorta was not able to wedge in between the two and it remained outside the circle, as it were, which is the reason why then the anatomy of the LVOT is different from that of a normal heart. So again, two circles, one anterior and one posterior in an anteroposterior axis, one for the aortic root and one for the common AV valve. In between, hopefully somewhere in the center, crossing at 90 degrees, there will be the interventricular septum, which could be attached to the leaflet or not attached to the leaflet. The presence of the interventricular septum does not separate the valves leaflet, as you can see here, but does separate the cavities. So that now we got the second element of the atrioventricular complex, which is that of a single atrioventricular connection that serves two separate ventricular cavities. In this case, the right to the right and the left to the left. You can see here the edge of the interventricular septum seen from above and some of the tissue of the leaflet attached to it. That allows you to identify, in this case the picture has been inverted, allow you to identify a left orifice to the right of your screen and a right orifice to the left of your screen. So, in terms of the different ways in which atrioventricular complex can present, again, it will not present in substantial difference in the fact that it's got a single atrioventricular connection, nor it will change the fact that the aorta is unwedged. but it will change on the element of this morphology that are variable. And what are the variables in this complex lesion? The arrangement of the valval leaflets, the size, the relative proportion, the presence of scallops and or zone of appositions, the relationships of these leaflets to the septal structure, and this implies both the ventricular septum and the interatrial septum, and the relationship of the common junction to the septal structures such as the perimembranous septum, the conduction system, the presence of an AV node, and the presence of a more or less represented interatrial septum. In terms of the valvar leaflets, which are probably from a surgical point of view, the most important element of the valve that the surgeon should be concerned with, generally speaking, the common AV valve has 5 leaflets. This is not surprising because if you think about how the valves develop, you have a 3-leaflet tricuspid valve and a bi-leaflet mitral valve. And so the valves that have not been separated, they still maintain the same number of leaflet components, in total 5. The arrangement of the leaflet can change, but normally we would recognize a right and a left mural leaflets, which are the leaflets that are attached to the part of the annulus or the atrioventricular junction opposite to the mid portion where the septum is. Normally you go 1 on the left, which is called the left mural leaflet, and 2 on the right, which is called the anterosuperior and a right inferior mural leaflets. And then you have bridging leaflets, and these are the very important one when speak in terms of repair. But these are the leaflet material that crosses at a 90-degree axis the axis of the interventricular septum. And these are the ones that need to be divided into 2 sides to share the same common leaflet material between the 2 new constructed valves at the time of repair. In terms of the presentation of the leaflets, there is an historical classification, the so-called Rastelli classification, that has got to do with what is fundamentally the anatomy of the mural leaflet on the right and the bridging leaflet in terms of the superior bridging leaflet. Mind you that what you are seeing here is a drawing of the echocardiographic representation of the valve, in other words, we would see on an echocardiogram. So you should try to imagine that you were looking at the valve if you were to cut the apex of the heart and look up into the ventricle cavity towards the valve. And so you're seeing the valve from below with the chordae and the papillary muscle coming towards you. You are not seeing the valve from above. Again, the Rastelli classification gives a representation of slightly different presentation of the leaflets, mostly on the right side and the superior bridging leaflet. Does this matter much from a surgical repair standpoint? I feel that it matters none, because ultimately the anatomy of those leaflets has got very little bearing on the way we're going to conduct our repair, and more importantly, it got very little bearing of the outcomes of this repair. And well, for outcomes, I mean the ability to equally share the leaflet tissue between the 2 sides and obtain valves, once they've been septated, that are functionally normal or as normal as they can be. In other words, open without obstruction and close without regurgitation. But it is interesting to see that in the Rastelli classification, one could include a specific subset of leaflet arrangement whereby the 2 bridging leaflets are linked by a tongue of tissue or a bridge of tissue that bridge between the 2 bridging leaflets. And that effectively, as you can see in this drawing, separates 2 orifices. That makes the life of the surgeon a bit easier because it gives you a reference point or where you're going to put your septating patches, because the valve has been somewhat already divided for you. Eventually, one of the most important, if not the most important consequence in terms of valve management, if we look at the classification of or the interpretation of the AV common valve, the way we have discussed so far, you realize that once you have divided the valve, you are supposed to find on the left side a valve that is made of 3 leaflets. There would be half bridging leaflet, superior and inferior, and the mural leaflet. The apposition of these 3 leaflets would be profoundly different from that of a mitral valve, of course, not least because it's 3 leafleted instead of bi-leaflet, but also because the zone of apposition then takes this Mercedes sign shape. And that is the fundamental characteristic of the left AV valve in the context of AVSD. When it comes to repair, this brings about a number of interesting features that are going to inform our repair. So keep in mind that at the end of the operation, the left AV valve, as we should be calling it, will have a superior bridging leaflet, an inferior bridging leaflet, and a mural leaflet at the bottom. I hope this is clear so far, so we carry on. So what are the surgical concerns? What are the things that the surgeon need to think about when dealing with the AVSD? I will, and I hope this is not too much of a problem for my audience tonight. I will not dwell much into the clinical presentation of AVSD, nor the specifics of how to diagnose or to manage preoperatively a patient with AVSD for 2 reasons. One is practical, it will take too long and it will prevent us from going into a little bit more into the surgical detail, but also because I believe that the correct practice is that of an interdisciplinary system where everybody got their area of expertise and deal with what they know best. Surgeons are not trained to diagnose. We are not trained in echocardiography. We are not trained in medical treatment. We are training in doing surgeries. And the best outcomes, in my experience, but in that also of many other centers around the world, is when those who are expert in their field come to work together. And so I would leave to the cardiologist the problem of diagnosing the AVSD, the intricacies of the vast array of phenotype with which AVSD can present, and also the type of problems that one can encounter when one tries to manage these children. But I will say this, because I guess this is probably a relatively easy thing to say and relatively quick. If you have a complete AVSD with an atrial shunt and a ventricular shunt, then the physiology will be that of a patient with a large VSD and a lot of left to right shunting, both with an overload of volume and pressure, which will overload the right atrium, the right ventricle, and the lungs if there is a large VSD. This in turn will turn into congestive heart failure, and the child will stop growing or will fail to thrive. These are normally the concerns that brings us to theater. Generally, when this situation is relatively balanced, allows us to undertake an operation when the child is about 3 to 6 months of age. But in some cases, we are not able to afford that, in which case we might want to buy some time with a palliation measure, which is normally the banding of the pulmonary artery to prevent the steal of cardiac output from the systemic circulation into the pulmonary circulation and prevent also the insurgence of pulmonary hypertension. If the problem of the AVSD as it presents is more of a valve regurgitation, which can be at presentation a significant problem, than that of a left to right shunt, then the PA band might not work so well, in which case we might need to offer an early intervention, and this is when things become a bit difficult. because earlier the intervention, the thinner the valve tissue is, and the risk of getting a repair that is suboptimal, especially for the left AV valve. So I will stop at that in terms of general indication for surgery. And we'll pick up at this point, that is, the patient requires your intervention, and the surgery with a repair cannot longer be delayed. And so as a surgeon, there are a number of things that you will have to concern yourself. And I don't believe that which type of Rastelli classification the patient presents with is one of them. What I would say that you should be able to instead form in your head a plan, a surgical plan, trying to visualize a three-dimensional structure, a three-dimensional repair, but using two-dimensional imaging, which is quite difficult, or at least requires a little bit of experience. The second concern is, will I have enough tissue to do all the things that I need to do, especially on the valve? The third is, will I have enough tissue to complete the formation of two functional valves? It's very difficult, it's very, I would say, uncommon to find yourself in a situation where you are unable to close the interatrial communication or even the interventricular communication, unless we are talking about certain specific subsets, which I will touch on a bit later on, namely AVSD in the presence of other complex lesions that can come together. But I would say that the valve tissue management is still the mainstay of this operation, and not least, prevent the complications. So here is a classic image, is a 4-chamber view. On the right side, you have the left ventricle. On the left side, you have the right ventricle. On top, you have a common atrium with virtually no interatrial septum. And then you have a single line, which is the crest of the leaflets, mural on each side and bridging leaflet in the middle, that are on the same plane, with a hole underneath and a large hole above. This is the classic 4-chamber view of atrioventricular septal defect. Now, this you need to use to construct your 3D repair. And as I said before, it is like saying that you need to repair a bouncy castle that has a hole on the side. Only that they call you and then tell you, I have a bouncy castle, I inflated it, I looked at it, it's got a hole on the side, can you come and repair it? You say, okay, I would like to know a bit more about this bouncy castle. They're not going to show you this image, they're going to show you this image. And then you say, well, from this image, I need to imagine how the bouncy castle would look like. So they might help you and give you this image. We'll give you a bit of three-dimensionality, but still on a piece of paper. Then you go to theater, you go on bypass, you paralyze the heart, and this is how the heart looks. And then you now need to go and look for your hole, repair it, and imagine your repair as if we was looking like this after you come off bypass. And once you've done this, this is how it's going to look on the echo to check your job. So you can imagine that it requires a certain amount of imagination on the part of the surgeon. So if you look at this image, it's quite useful because it gives you the 3 planes and the 3 or 4 orifices that we need to deal with when we repair AVSD. There's the plane of the septum, which goes across the whole of the heart from the back to the front. Superior is the interatrial septum and inferior is the interventricular septum. That's plane number 1. Then the second plane, and the plane which is orthogonal to that plane, is that of the common AV valve. Then there's the third plane, which is the anteroposterior diameter of this heart, which also needs to be taken into account when we are talking about a 3-dimensional structure. We got so far 2 orifices, that of the valve, and then you got a third orifice, that of the aortic root. Luckily enough, in most cases, the orifice of the pulmonary valve is out of the game. But if, for example, you have AVSD in the context of double outlet right ventricle, that also plays into your considerations. And so you got 3 planes and 4 orifices to take into account. We talk about the Rastelli classification. Again, from a surgical point of view, I think the Rastelli classification might have had some merit historically. But today, I would think that the most important element is a precise description on the part of your cardiologist of how the valve actually look. How many leaflets are there? How big they are? Are there clefts in these leaflets? Are there a lot of chordae? And more importantly, what is the size of the left mural leaflet? Not that I'm not interested in the size of the right mural leaflet, but repairing the right AV valve is normally not that difficult. Repairing the left AV valve is more consequential because a problem with that repair might give you left AV valve regurgitation. Working under systemic vascular resistance and systemic pressure, left AV valve regurgitation becomes, of course, much more consequential than right AV valve regurgitation. So as a surgeon, having to manage this lesion, this is the information that you want to have. And there are fundamentally 3 scenarios. Well-balanced mural leaflets with plenty of tissue that we can separate between the 2 sides. And once we have made the separation, we are left with plenty of tissue on the left, 2 papillary muscle, and a large inflow area of this valve. We can have scenario number 2, where you have a similar conformation, but the leaflet material on the left is not of such good quality. You can have different clefts, asymmetry in the leaflet material, a inflow valve that might be smaller than what would you like, but still acceptable without having to make additional substantial interventions on the valve to make it functional. The last one is actually a nightmare scenario. The absence of a mural leaflet turns the left AV valve into a bicuspid valve, normally associated with a single papillary muscle. These valves are particularly difficult to treat, and obtaining a valve that is not stenosis incompetent at the same time, I would say, is very, very difficult indeed. And fundamentally, I would say that I ask my cardiologist, is there a mural leaflet? How big is the mural leaflet? Are there 2 papillary muscle? Everything else I can manage. But scenario number 3 is very, very difficult to manage. And you need to tell this to the parents, because if you are going to consent for repair of AVSD, you will have to tell these couple of parents that their baby might end up with a mitral valve replacement, a need for intense medical therapy, prolonged recovery period, and probably a number of reoperation. The patients that I have lost in my career to AVSD, luckily enough, only 2 out of about 200, but I lost them in this scenario, i.e. with a very diminutive mural leaflet and a single papillary muscle. When it comes to the traditional gooseneck LVOT or tortuous LVOT in the context of AVSD, the gooseneck definition is an angiographic definition. You wouldn't see a gooseneck LVOT on a CT scan, MRI, or even on the echo. But traditionally, they used to do angiograms to diagnose these lesions. And this is how it looked like on the angiogram. It is because the aortic valve is unwedged. And so the outflow tract needs to go around the plane of the common AV valve and meet the ventricular cavity underneath. That's why it's got that prolonged course. The principle of surgery, as we said, when you plan your operation, should include closing all interatrial and interventricular communication, reapposition of the bridging leaflet unless contraindicated on both sides. The reason why we do that is because we want to leave only a single apposition in every valve. We don't like a trifoliate valve on the left side. An elegant paper by Professor Carpentier from the early 2000s showed that if you don't close that zone of apposition between the 2 bridging leaflets on the left side, you almost invariably end up with a very leaky valve at some point later on in life. This afternoon, I saw a 24-year-old girl who's coming for repair of AVSD and has got a very severe left AV valve regurgitation because the zone of apposition was never closed. And that is just one example. You should do that by avoiding the atrioventricular block, which is not uncommon due to the specific anatomical position of the conduction system in the context of AVSD, and prevent LVOT obstruction. What I will discuss today is a specific subgroup of AVSD, and that is one with balanced ventricular mass, or so-called balanced AV canal. The unbalanced AV canal is fundamentally the situation where the presence of a single atrioventricular connection is associated with other problems, and more importantly, with a imbalance in ventricular mass distribution and cavity. And fundamentally, the difference between these two groups is that whether the first one can be repaired into a biventricular circulation, the second one cannot, because if we were to septate the heart, i.e. close the interatrial and interventricular defect, we will end up with a cavity on one side that is much smaller than what is needed, i.e. an hypoplastic left heart or an hypoplastic right heart. And therefore, the presence of an unbalanced AV canal, especially in the extreme section of the spectrum, will effectively put this patient down the route of a single ventricle circulation. Are we doing the atrioventricular partitioning, or the separation of the two chambers above and below the plane of the valve, using patches? If there is no significant defect below the plane of the valve, i.e. a VSD, then a single patch will be enough to close the hole between the two atrium, i.e. the interatrial communication, or primum defect, as it were. By doing so, you also separate the valve. If the valve are already attached to the crest of the interventricular septum, they're probably already somewhat differentiated, but probably to a lesser degree than normal, into a right and left valves. We can have a double patch technique, which are the one that I prefer in the context of a complete atrioventricular canal, where you have a communication above and communication below the plane of the valves. Or you can have a more traditional excuse me, a more traditional approach, which is that of a modified single patch in the context of a complete AV canal. I personally believe that this technique is inferior to the double patch technique, especially when the interventricular communication is particularly deep. And we can discuss perhaps later on in the discussion why I believe that to be the case. But I would say that in Southampton, certainly we would be offering to our patients a single patch technique if there is no interventricular communication, and a two patch technique if there are atrial and ventricular communication defects. The one thing that is very difficult to learn, and it takes some time, and it's one of the experiences for every surgeon, probably now with the advent of surgery on 3D model, that might be mitigated a little bit. But so far, when people have to learn on patients to gain their surgical experience, this is probably the most stressing part of the operation, which is the shaping and the sizing of the ventricular septal defect patch. You can see in this drawing how this change in shape of the patch will alter fundamentally the geometry of the valve once it has been cut into two, well, it's been separated into two. And you can see that a patch too wide will prevent the bridging leaflet to come together. A patch too deep will also prevent the bridging leaflet to come together, but also will move the bridging leaflet away from the mural leaflet. In other words, missizing the patch is very likely to lead to a valve incompetence. So let's see how a repair of AVSD using a two-patch technique looks like in theater. I hope you can see the movie. I can't hear you, so I assume that silence is
yeah, we can see it. We can see it.
Very good. So here we have a very dilated heart. Both the right atrium and the right ventricle are quite distended, dilated. We went on bypass, we drained the heart, we cross-clamp, and we cardiopleged, so that now the heart is empty, flat, and flaccid. We would access the valve through an incision in the right atrium. Now we are seeing what I am seeing, as if you were the surgeon. The camera is mounted on my front. We are testing the valve first to see the anatomy of the leaflet when they are distended, the distribution. And you can see here the mural leaflet, the two bridging leaflet, and a midpoint. This is what allowed me to shape the patch. And for this particular case, the best shape, as I can see it, is that of a semilunar patch, which is attached, as you can see in this drawing here, to the crest of the septum, normally with a continuous suture. It is normally lying on the right side of the septum, and then this thing will stand proud just underneath the bridging leaflet that have been lifted to show you the patch, and that will fill the gap of the septum underneath the plan of the valve. Having done that, and having separated the valve tissue into the left and the right side, we then take a second patch. Normally I use the autologous pericardium for this, and we will attach that patch with interrupted sutures that start from the free edge of the first patch and go through the free edge of the second patch. So the two are now stitched one on top of the other. Now I'm cutting the patch off the pericardium, so that now the second patch is standing alone. Now I'm looking on the right side of the patches, so that is the new right AV valve. Then the second part of the operation begins, where I flap the patch in front of me towards the right, and I look at the left AV valve now. These are the two bridging leaflets, the inferior bridging leaflet and the superior bridging leaflet, and this is the mural leaflet. And I will now stitch the two bridging leaflet together, because as you remember, I said before, Carpentier says that if you don't do it, this leaflet over time will grow apart and will become very incompetent, will make the valve incompetent. So I want to make a straight line between the two bridging leaflet. I don't know if you can see my little hand here. And I put interrupted sutures between the two bridging leaflet to close that gap. That gap, Professor Anderson calls it the zone of apposition. So it's not a cleft, it's a zone of apposition, because remember, this does not originate at the annulus of the valve. It is the line that was in the middle of the common orifice between the two bridging leaflet. So it's not a cleft. Once we close that, we test with serum whether the valve is competent, and it's competent, but to a point. When the valve still leaks after the closure of the zone of apposition, we can add some techniques to make the valve a bit tighter, as it were. And in this case, I'm doing a bilateral commissuroplasty, which you can see in the drawing on the bottom right, which fundamentally restricts the annulus of the valve and brings the leaflets a bit closer together. This diagram is meant to illustrate the type of commissuroplasty that you would do, and you can see the valve is much, much more competent. There's no water leaking back. At this point, we complete the septation of the heart by closing the interatrial septum using that second patch that we attached to the first one. That closes the so-called primum ASD. We do that by leaving the coronary sinus to the right, so that the drainage of the coronary sinus is physiological, and avoiding the conduction system as much as it is possible. Once we finish the operation, we close the heart, we come off bypass, we look at the echo, we check for good ventricular function. You can see the patch that closes the VSD. You can see the edge of the zone of apposition of the left valve being closed here. You see the patch that closed the ASD, and that completes the repair. So at the end of the procedure, I want to see this again, only that this time I would have put stitches along the vertical line to keep the inferior and the bridging leaflet closed together. The technique by which we close the zone of apposition also merit a little bit of attention, and the trick is to use interrupted suture so we don't shorten this axis here, so that we keep the good apposition between these complex formed by the two bridging leaflet and the mural leaflet. If we were to do a continuous suture, this might get shortened and create a gap in between. In this case, this is exactly what happens. There is a gap between the two bridging leaflet and the mural leaflet. This can be mitigated by putting stitches on the posterior or mural aspect of the annulus to bring that mural leaflet forward to meet the bridging leaflet and create a better competency. The way we pass the stitches is to use as much material as we can, because remember that this valve will be subject to systemic pressure. And so the leaflet, especially in the very young one, has to be as solid as possible because they can easily tear through. We talked about the additional maneuvers, and there are some advanced techniques that can be used in valves that are particularly challenging. One of those is to anchor the mural leaflet to the zone of apposition, creating a two orifice left AV valve. If you are in this situation, probably you're dealing with a very difficult valve, and the result might not be ideal, but it might be enough for you to be able to come off bypass and the child to grow enough to get the annulus of at least 16 millimeters that would allow you to replace the valve if this valve was very dysfunctional. More advanced or sophisticated, the technique include also the addition of patch material to augment the leaflet tissue to make the coaptation of the two portions a bit more effective. Just a reminder, in the case of what the surgical community, probably a bit mistakenly calls a partial or intermediate AVSD, i.e. where the leaflet are attached to the crest of the interventricular septum so that there's no VSD technically, then we can use a single patch technique, which will not alter the geometry of the valve. But in doing so, we need to make sure that we don't pass the stitches inside the bundle of vis that runs just underneath the leaflet. So that is the pitfall for that particular procedure. The conduction system is misplaced because absent the cushions of the embryological formation of the crux of the heart or skeleton of the heart, we miss the formation of a membranous septum in the position where we would like to see a membranous septum, and therefore the replacement of the conduction system more inferiorly and towards the coronary sinus. This is exactly where we implant both the ventricular and the atrial patches. And so there is certainly a degree of attention that needs to be placed when implanting the patches below and above the valve tissue to avoid the conduction system. AV block in the context of AVSD can actually carry significant morbidity, and it is something that we need to try and avoid very carefully. A short comment about what I was saying before, that is the relation between the orifice of the ventricular arterial valves, i.e. the root of the pulmonary and the pulmonary artery and the aorta, and the plane of the atrioventricular valve. Normally, you would have the aortic valve wedged between the two vessels, and the pulmonary just a little bit to the outside of that. In AVSD, both truncuses are very far away from the plane of the atrioventricular valve because it's a single orifice. But there are certain characteristics or certain subsets of AVSD, like the one on the right side here, which is the AVSD in the context of a double outlet right ventricle. So you have the plane of the valve with an orifice to the left and an orifice of the right. But then out of the right cavity, both artery comes out, both the aorta and the pulmonary artery. And so you can imagine that closing the VSD in the traditional way would leave the aorta to the right ventricle and no outflow to the left ventricle. And so in the context of AVSD with the double outlet right ventricle, our patch will have to be shaped in such way to leave a communication between the cavity of the left ventricle and that of the aortic root. When it comes to the complications related to the anomalous position of the aortic root and the compared to that of the left ventricular cavity, you can see in this post-operative MRI of someone who already underwent repair of AVSD, a large left ventricular cavity, well represented, good muscle, a left AV valve, we don't call it a mitral because it was never a mitral, an aorta, which is far away from the plane of the valve. It should be here, but is up here because, as I said, this was originally an atrioventricular valve. This is a section of the right atrium and a little bit of the right ventricle. You can see, though, that this is the aortic valve annulus, which is of an adequate size. But already just below the aortic valve annulus, the channel, the LVOT, is narrower than the aortic valve annulus. And that has got to do with the position of the superior bridging leaflet of the left AV valve, which unfortunately is a bit more moved towards the interventricular septum than what we would like to see. But there is even narrower bit, which is where the superior bridging leaflet is particularly pulled towards the interventricular septum by some remnant chordae that were not resected at the time of the initial operation, and are pulling this leaflet towards the opposite side. There's also, again, a relatively central position of the left, of the superior bridging leaflet, and then a normal position of the papillary muscle. So, what does that illustrate? It illustrates the potential mechanisms of post-AVSD repair obstruction of the LVOT. Normally, these are either attributable to a malposition of the superior bridging leaflet and the presence of secondary chordae that should have been removed at the time of the first intervention, precisely to avoid that central pull that you can see within the red angle. Normally, therefore, the redo operation for subaortic stenosis in the context of AVSD will have to take into account all this anatomical and require an attentive analysis of the LVOT to identify exactly what the mechanism is. Echo is good to a point. TOE can be very helpful, but I would say that the MRI is probably the most helpful of all, because it gives you a full picture of the root, the ventricle, the valve, the atrium, with the clips, i.e. in movement. And normally I would say that if I can get a hand of an MRI, I'm able to understand relatively quickly what the problem is. And as you can see in this illustration, the problem was both the chordae and the position of the leaflet that had to be moved away, as you see between B and C here, had to be moved away from the attachment as in the original operation and augmented with an interposition graft, fundamentally to place more room on the roof of that LVOT. The majority of surgeries today who have learned from experience over the first 20-25 years of treatment of AVSD are now quite cautious, and it's part of the standard operation to look underneath the superior bridging leaflet and make sure that all secondary chordae have been resected. And potentially we see a bit less of LVOT obstruction, but occasionally it still come back. This is historical data now, it's probably 15 years old. And at the time, this was referring to the 10 years previous. So this is data that is 25 years old. So probably a bit historical from that point of view. But I would say that 10% of the patient with AVSD might recur with LVOT obstruction. I would say probably the prospective experience would bring that prevalence down to probably below the 5%. But there is a subset of patients, and you can see down here, which is the one with aortic arch obstruction that will have a near significant p-value when you look on multivariate analysis as a risk factor for LVOT obstruction. And that reason is that these are those who have the association of Sean type problems with AVSD. In other words, people that will have the tendency to have obstruction along the left route, pulmonary veins, mitral valve, LVOT, aortic arch, as you will see in Sean syndrome, but associated with AVSD. And in these cases, even a good repair of the AVSD might still bring about an LVOT obstruction because it could have come anyway, simply because they got a Sean type complex. As I said, in the context of associated lesion to AVSD, one of those is the double outlet right ventricle, another is the tetralogy of Fallot. The shape of the patch will change significantly to include the aorta to the left side, of your interventricular patch, which means that the patch needs to be much bigger than what you would normally make. But in the context of tetralogy, we also need to deal with the RVOT. I'm not going to go into the detail of how you treat the RVOT in the context of tetralogy of Fallot, because that is another topic. But certainly you want to get to the position where the outflow tract of the right ventricle is unobstructed, hopefully preserving the pulmonary valve. When we are talking about double outlet, I think I showed you this already. The shape of the patch, which has got these almost two segments, one to close the VSD and one to tunnel the aorta, need to allow the blood to come up from the left ventricle, come under the patch, over, across a portion of the right ventricle cavity, and into the aorta, with or without the augmentation of the right outflow tract. Luckily enough, double outlet right ventricle and tetralogy are not commonly associated with AVSD, nor are all the other lesions that you can see here. But oftentimes we see an additional atrial septal defect, which is of no consequence because it will be repaired at the same time, and in the preoperative period fundamentally doesn't add any specific burden to the circulation. But the patent ductus arteriosus instead is a different matter, because then now you have a left to right shunt at ventricular level and an additional left to right shunt at ductal level. And these are again shunts that goes into the lung from systemic circulation, that is systemic pressures. And so the combination of AVSD with the large VSD component and PDA put the child in severe cardiac failure very early, normally in the neonatal age. And these are patients that need to be intervened on with probably palliation measures, including the ligation of the PDA and the banding of the pulmonary artery, quite often, because you can't afford to wait for them to grow in order for you to be able to do the complete repair. The rest of the lesions is very rare. I would say I haven't seen most of those in my practice, but I have seen the association of AVSD and transposition, that is transposition of great arteries, which is exceedingly rare, and that was a girl that came from Eritrea. But other than that, normally I would say, apart from secundum ASD and PDA, the most commonly associated with AVSD in the non-heterotaxy group, i.e. with situs solitus and concordance of atria and ventricles, are DORV and tetralogy of Fallot. What are the risk factors for mortality, which is already quite low? I would say that nowadays in the UK, by the national database, mortality for AVSD is less than 1%. You can still have significant problems in the context of heterotaxy syndrome. unbalanced AVSD, bad absence of a mural leaflet on the left side, because these are those that make the operation very complex, the patient very unbalanced, very unstable. In some cases, they will oblige you to go down the single ventricle route, like in the significantly unbalanced AVSD. And in the probably less aggressive or less malicious scenario of a bad left AV valve left AV valve anatomy, they might oblige you at least to a number of reoperations. If you look at outcomes by repair, again, this is historical data. There are probably no significant difference when it comes to crude survival and both in early and late mortality. So the modified single patch technique, about 2% mortality on the first published series, about 200 patients altogether. The two-patch technique, 3 or 4 times as many patients, a much wider experience worldwide, and a slightly higher mortality, I believe, because they were including more difficult, smaller, and sicker patients. And the classic single patch technique, which is fundamentally not practiced anymore, and it would be used only in very specific cases, I think the mortality reflects mainly the historical experience. But when it comes to left AV valve regurgitation, it is interesting to notice that the classic single patch technique has much more left AV valve regurgitation compared to the two patch technique, for the reason that I was mentioning before, and that is that if you use a single patch to push your valves all the way down to the crest of the septum, you are expecting the leaflets to run a much longer course. Because of the triangle, now the leaflet has to be the hypotenusa and not the long side. If that triangle with a 90-degree angle at the crux between the atrial septum and ventricular septum and the plane of the valves was to be pushed down to the crest of the ventricle, of the ventricular septum. Either way, even in the worst case scenario, mortality has dropped significantly. As I said, the UK experienced the mortality overall, all included, apart from those who go into the single ventricle route. So all two biventricular circulation repairs, the mortality is less than 1%. And with that, I will finish my presentation and I'll stop sharing. Thank you for your attention.
Thank you so much, Mr. Viola. It was amazing, and honestly, you're one of the best speakers I've ever seen, just because you explain topics that are so complex, and you make it seem like anyone can do it. But
you will do it one day, so you better get on with it.
I hope one day. Are you happy to take some questions? There's some already in the chat, if that's okay.
Yes, by all means, carry on.
Yeah. So Laiba has asked, I've seen research looking at modeling of congenital heart defects to create 3D models. How useful do you think that this would be in your practice? Some people have said that they didn't believe it was beneficial in the surgery, but it's useful in the patient consultations.
The usefulness of 3D modeling is, apart from the educational in the grand scheme of things, of allowing people like you, like us, all of us really, to see the anatomy in real time, and not like that deflated bouncy castle, but see the bouncy castle when the bouncy castle is inflated, because that gives you the true 3D dimensionality of this repair. The main problem is that we are still yet to be able to integrate data that allow us to add valve tissue to the standard 3D modeling. At the moment, the primary data for 3D modeling is that of cross-sectional imaging, mostly CT scan because of the granularity of the data that we can get, especially with the 128 scanners that give you 128 slides in less than I think a second and a half. So a lot of data that you can use to process. But eventually, and this is what we do with our partners in Belfast, for example, that builds up the walls, which is muscle. And the valve at the moment is not captured by the CT scan, even the fastest scanners. The point with the AVSD is that the muscle in this equation, i.e. the crest of the interatrial septum and the crest of the interventricular septum, is just the hinge point. What you are doing, you are shaping your patches to keep the valve on the same plane, to not move the patch too much to the left or the right. So in other words, to give too much tissue to one valve compared to the other. And that is what makes this difficult, the operation what it is. So a 3D model that doesn't have the valve tissue fundamentally is not helping you much, because it's taking away that element of the repair that is the fundamental element. Now, that is not to say that this will never happen, because we are working at integrating data from other sources, maybe 3D echo and MRI, to do precisely that. Once we have it, I believe that the most important element would be to train you to size that famous VSD patch, which is the one that, if you think about, sets the geometry in motion, because it will give you the separation of the valve, the width of your common AV valve, and the height of the leaflets on this plane. If you get that right, you need to get the 90 square cross in the middle of your picture. That requires a little bit of experience to shape it, because there are no mathematical algorithms or even instrument that can measure it in a proper way. And everybody over time develops their tricks to do that in a consistent and reproducible manner. But the problem is that it's very difficult to teach. In other words, the difficulty of AVSD, apart from the presumed ability to imagine a 3D reconstruction on 2D information, is that you need to be able to communicate that same thinking to somebody else whose brain might work different from yours. And there are very little markers that we can use to speak the same language. The 3D model eliminates that, because you got the model and you can try as many times as you like, because nothing will happen other than putting more stitches in the model. And this is what we are working on, because, and as you know, we've been talking about this and we are working towards the preparation of the course for next year. Once the models are available and they're there, you can come, sit around the table, and you can play the whole day in shaping as many patches as you want until you get the right shape for that heart. And once you get that kind of thinking going, then the AVSD becomes reproducible and consistent in outcome.
Yeah, I think that answers it very well. So it's a topic that touches home for me, because I'm spending this year on 3D modeling actually for the pre-op planning. And like you said, one of the biggest things that we see is the inability to get the leaflets of the valve. So even you can get very good things like papillary muscles. You can even sometimes see the remnants of the cords. So you can kind of guess what the valve could look like by looking at the annulus. But even then, unless you have good echo, unless you have multiple imaging with the 3D models, you can never truly get that picture yet.
For those of you who are in the UK and those who aren't, just the same, I would like to share with you now. I'm gonna be a technological kid like you. I'm gonna share with you a photograph, if you allow me.
Yeah.
And there you go. So I'll share my screen again.
That sounded like airdrop.
Yes, that because it was airdrop. Because I'm snazzy that way. I want to show you this. Can you see this?
Yeah.
So this is the first UK library of 3D printed arts that we opened yesterday at UHS. There are at the moment about 70 hearts on display. Soon enough, we'll have a QWERTY code on every heart that will drag you to a website that you can see on your phone or iPad if you want to use that and you've got Wi-Fi. And it allow you to navigate these models as we did when we planned our operations. 3 of those have a AV canal as part of their complex lesions, and you will be able to see, at least in all of them, the single valve orifice, which is also, or in the list, the concept that everybody should walk away with. One day we'll have the leaflets as well, but for the time being, if you were able to nail down the idea that there's a single annulus and a septum in between and a septum above, and all you do is to create the continuity of that septum to separate the two valves, you moved along a great length.
The collection is brilliant. I mean, we've seen, me and Natasha, at least, we've seen some of the hearts from the collection.
You saw the previews, right? Now the collection is on display. Yeah.
Yeah. And did you finally figure out how to get your incubators and keep them warm and all the technological things?
We're working on that.
No, but it's amazing to have these type of resources, because even understanding how the valve looks like when you're in theater is very different to like the diagrams, because you see them as a flat thing, and you expect to see that in theater. Then the first time you go, you realize the valves are at like this kind of plane when you're looking at it, and the ventricular septum is actually coming at you at an angle. Understanding that is, you just don't get the justice from pictures. You just have to see it in 3D.
But that's why I think that this is a fantastic forum, because our generation experience is that you would become a consultant and then you start to deal with this, and you will have to do it on the patients. And apart from the specific interest that obviously you are a selected group of people with particularly heightened enthusiasm, which is great to see, but ultimately nobody wants to apply a learning curve to live patients whenever is possible, of course. And the revolution that the 3D will bring is that I probably not entirely, but I expect your generation to come to theater with a fair good idea of what you are going to encounter when you actually are in theater with us, which will make the relation between you and your surgical mentor much more straightforward, because you will have already developed a kind of a common language. And so I do think that removing that awkwardness, that difficulty in theater there and then, to a wet lab where you can actually trial the operation, will maybe not eliminate, because obviously I can't vouch for interpersonal relations, which are a significant part of education and training, whether we like it or not. But how many times have we seen or we felt, nice people, but they don't let you do anything. Great center, but you just observe. There is a reason why that happens, and I'm not saying that is the right reason, but unfortunately is in most cases a defensive mechanism that we can take away now. And you and I can do all the surgery that we want, because we will do it on somebody that is not going to walk away after this. But the techniques are the same technique, and the materials that we use allow us to actually train your wrist and your fingers to use your needle holders as a pen. It took me a very skilled surgeon, a very fast learner, 2 years to tell him that he needs to move the needle holder like this and not like this, because this is much refined and this is very awkward. Or that you need to have the angle of attack prepared in advance before you hit the tissue. And all this will go away because you will do it on the 3D model. The 3D model allows you to do that. All right, enough ranting about the 3D, I guess.
No. And we have a few more questions as well. Someone's asked about redo adult patients who've had a previous AVSD. Is the valve replacement technically the same as it is, or in these AVSD patients, because you don't have a kind of distinct valvular annulus, so to say? Do you have to
Well,
rely on other things
you are
like?
very, very well informed people. I could ask you the question, and I should expect to give me the answer, but I'll cut it short. And plus, you are not on the stage. Is me under the spot. But obviously, if your aortic valve is not wedged, then the first thing that happens is that you don't have an aortovalve mitral continuity, right? So your anterior portion of the annulus on the mitral side or the left AV valve side lacks the aortomitral continuity. Number one. Number two, if you remember the normal shape of a normal mitral valve, the apposition of the leaflet is a smile, right? Like a smiley. In AVSD, the smile goes this way, the opposite way. So your commissures are not here, are here. Third, in AVSD, because we have a common orifice, the papillary muscles are rotated clockwise when you look on echo from below. So if you look on the echo from below, imagine you're looking up in the ventricle, having cut the leaflet, having cut the apex, you would have the two papillary muscles in this position. Now they are clockwise, they are in this position. So when you put a valve in, you need to remember that, especially if it's a biological valve, the struts of the valve, you don't want them to go on the wrong position and impinge on the papillary muscle. 4, the shape of the LVOT is different. We said that because it's got this unwedged position of the aortic valve. This is, in a sense, good news because we can put the valve more posteriorly compared to the position of the aortic valve. So if you're using a tissue valve, the struts of the tissue valve are not going to impinge in the LVOT. This is different in the neonates. I'm not going to go into that, but we're talking about adults. Last, the position of the conduction system is different. If you remember, is not anymore on the other side of perimembranous septum. So when you put your interrupted or continuous stitches to implant a mitral valve, you run the higher risk of ending up with AV block. Last but not least, the anterior leaflet is your previously implanted patch. If that patch calcified, all the anterior stitches on your implant are now going to go through a calcified patch. Because you remember your anterior annulus is the interventricular patch as per previous repair, right? So what you want to know is, before you go to theater, if that patch is calcified, because if that patch is calcified, you need to take it out. Otherwise, you got nothing to stitch on. You can't pass the stitch on. In the calcific mitral valve annulus in the acquired domain, so adult cardiac surgery, we can use advanced techniques of decalcify the annulus, then we can repair the annulus, recreate the atrioventricular continuity and whatnot. But if you remove the decalcification from your patch, you're removing the patch. If you don't replace it, you ended up with a VSD, right? And nothing to stitch up the anterior valve on. So these are the main characteristics of AV surgery in the context of a repaired AVSD.
Oh, okay. You don't really think about a lot of the relations, especially when you think of the AVSD as just the AV valves, but you forget about the unwedging of the aorta when you look at it, and sometimes you forget that the aortomitral curtain serves as a very good kind of landmark and positioning on even a aortic valve replacement, and just understanding the position of the aorta in relation to the rest of the heart, because it's the centerpiece, really makes a difference, I think, especially in AVSD.
Yes.
Yeah. And I was going to ask, how do you approach so-called canal type AVSD? Or I know some people say the perimembranous VSD with the inlet extensions, because the conduction axis, it's very similar to the normal conduction
We are
axis.
moving away now from AVSD. Yes?
Yeah. It's that kind of gray area where some people call it as part of the AV atrioventricular.
Okay. So it will be my job to get you to walk away without gray areas.
Yeah.
What we call the canal type VSD i.e. a perimembranous VSD with an inlet extension, has got a fundamental difference that puts it in a completely different category from the interventricular communication in the context of a VSD. And what is that fundamental difference?
There's no primum component or atrial component.
No. What is the difference between a VSD of any type and the AVSD of any type?
The leaflet.
Lack of the endocardial cushions.
Sorry?
Yeah. I was going to say the leaflet patterns.
Oh,
The
dear.
endocardial
I
cushion.
failed you.
The endocardial cushion doesn't.
The difference is the common atrioventricular junction. The conformation of the leaflets can vary, but what you will not have in any type of VSD is a common atrioventricular junction, because at embryological level, that heart got septated. The cushions were there. The two valves developed with two separate atrioventricular junctions, a right and a left one. So the fact that the AVSD and the perimembranous VSD with an inlet extension have got in common the position of the shunt in relation to the rest of the interventricular septum, that is true. But one is a defect of the interventricular septum in the context of two separate atrioventricular junctions. And one is the communication between the ventricle that lies underneath the plane of the valve in the context of a single common atrioventricular junction. Now, in terms of repair, you don't have a primum ASD. And so to repair the VSD, in the context of perimembranous with inlet extension, you would repair that as you would repair any other VSD, i.e. through the tricuspid valve orifice, but you don't even go into the left atrium. You don't need to, because the mitral valve is completely separated. Besides, that is a tricuspid valve. He hasn't got bridging leaflet. He's got a septal leaflet, an anterosuperior leaflet, and an inferior leaflet. And then you will have a ventricular cavity with a septum and a hole anywhere. It could be outflow tract, it could be inlet, it could be apical, it could be muscular, and so on and so forth, or perimembranous in all its various configurations. But again, you have a completely separated orifice from the left AV valve.
I see. I think that we had a case recently of a canal type, and it was diagnosed as an AVSD. That's why I thought I'd ask the question to understand your.
By the way, the canal type VSD, I suspect I would consider it an historical definition of what a VSD with an inlet extension is. Because it's confusing, by the way. It makes you think that it's almost like an AVSD, but it's not at all an AVSD. And so I would invite you to use current classification of VSD that are readily available, which will not include the canal type of VSD. There's an old term. You would have a perimembranous VSD with an inlet extension, or an inlet VSD, which is, by the way, well, it's not the most common, but it's not that uncommon. Now, back to your question. In a context of a completely separate system of right and left atrioventricular junction, for simplicity, a tricuspid annulus and a mitral annulus, we know that the normal conduction system will be originating at the apex of the triangle of Koch, just short of the membranous septum, where the AV node is placed. You would have a passage between the AV node, which is embedded in the atrioventricular junction just next to the septal leaflet origin, below the septal leaflet, and cross across the septum with the so-called bundle of His, that will be then divided into a left bundle branch and the right bundle branch, which then wriggles off, right? If you have a perimembranous VSD, that area of muscle is absent. And so your conduction system will have to go on the inferior side of the edge of the VSD going around it. If you have an inlet VSD, which is at the other end of the inferior part of the septum, then the conduction system will be to the left of your defect, looking down the tricuspid valve. This is perhaps could be the topic of another discussion with some illustration, because without seeing it, I guess it's a bit difficult to keep it in mind. But in that regard, the conduction system of the AVSD is that of the conduction misplacement in the context of a perimembranous VSD, but in a very different position from where the perimembranous VSD is. And therefore, I understand why people will try to make this connection, to try to, I guess, make sense of it, because there's a great variability. But I do think that it's more important to study the lesion for what it is, in its inherent characteristics, and go through every aspect of the lesion as it is, rather than trying to say, oh, it's quasi or is similar to, because that creates more, I think it opens the door to some confusion, which is not helpful. What it is helpful is to highlight what is the fundamental characteristic of every lesion, the non-varying characteristic, account for the variables, but if you are very clear on what is the thing of that lesion that does never change, then you are able to pinpoint that lesion to its fundamental anatomical characteristics, that when you speak to the cardiologist, you both know what you're talking about. And when the cardiologist presents the echo to you, you will have a common language to refer to. And that is, in my mind, I do believe personally that this is the most successful recipe for a good practice. And ultimately, if you follow that rule and you talk to your colleagues, you are able to engage in complex lesions and possibly bring home the results, which is what we all want.
Thank you so much for answering the question. Do you have time for one more? There's, I think, one more in the chat.
Go on then.
Yeah. So someone's asked, have you seen any applications of virtual reality or anatomical modeling as preoperative planning? And I think as an add-on, they've also asked, how do you decide on patch materials?
Okay, so virtual reality, yes. Again, virtual reality uses the same primary data as our modeling. And so if you don't have CT scan that shows you the leaflets, you will not have the leaflets in the VR. Is different from those who are now building models to be used in VR, where they can build whatever they like, because they build fantastic video games. They can also build fantastic hearts. But that is different from primary data from a patient. I'm not saying that it's superior or inferior, it's just a different matter. Now, if you are planning an operation for a specific patient, then you should use that patient data. The valve data is not available. From a surgical point of view, what I would say about VR, that the one in our unit that has a VR is a cardiologist, is not a surgeon. And probably there's a reason why, because VR is very powerful in understanding the morphology. And it's fundamental, because again, it creates that kind of commonly shared knowledge, but everybody can understand the morphology. But when it comes to surgical planning, you are as clueless as before, because you can't touch anything. Whereas if you have a 3D model, we are practical people, and you want to learn how to cut a patch, you actually need physically to cut a patch. And on VR, you cannot cut a patch. But if you have a model on your desk, you can cut a patch. So VR is fantastic, is extremely useful to understand complex anatomy. I personally found it a bit less, at the moment, at least for now, a bit less useful in planning or training myself for an operation. And as for the patch, yes, we do use autologous pericardium to close the atrial portion of the AVSD. But for the ventricular portion of the AVSD, we use treated commercial pericardium because the pressure is too high.